I thought I would share some interesting patient cases that have significant dermatologic and infectious overlap in order to help highlight the importance of cutaneous manifestations in the world of infectious disease. And so the objectives of today's talk will include a review of multiple case presentations with significant dermatologic manifestations of infectious etiologies. I hope to highlight the importance of a comprehensive evaluation of patients' cutaneous manifestations, but also of their review of systems and any associated comorbidities that may be playing a factor in their presentation, subsequent treatment plan, and any sort of complications that may arise. I hope to also identify key therapeutic strategies when treating cutaneous infections and when they're associated with systemic involvement. And then last, but probably the most important element that I would like to highlight during today's talk is that you never stop one's workup when there are lingering questions. Always advocate for your patients if something just doesn't quite fit right. And so with that, I will go ahead and start my case presentations. So for case presentation 1, the history of present illness, pretty exhaustive, but I'll walk you all through it. And so while I was on my rotation at the VA Medical Center, at the dermatology clinic down in Richmond, a 37-year-old Puerto Rican male who is a construction worker with a several-month history of a painful left foot presented with the following history. And of note, the patient had actually presented to the ER, but we got an urgent call from one of the providers there stating that they were at a loss as to how to treat this patient, and they were hoping to see if we could add him in on an urgent basis in the afternoon clinic, which we were happy to do. And so the patient's history that he reported to us was that he had arrived from Puerto Rico several months prior with a left foot that was pretty painful and swollen. He also reported that there was this malodorous smell that was difficult to manage during his dressing changes that he was just doing at home on his own. And he also mentioned that prior to his evaluation that he had been evaluated several times by both podiatry and the emergency medicine physicians and providers, where he'd received multiple courses of the following therapies. This included both topical therapies and oral antibiotics and antifungals. And so the topical remedies that they had prescribed and recommended varied anything from clotrimazole, topical steroids such as triamcinolone, Gentin-Violet, and Silvadene. And he had been on multiple courses of doxycycline and fluconazole, anywhere from a 17 to a 14-day stretch at a time. And of note, he'd only ever really achieved a partial response to either the doxy and or fluconazole. What prompted his visit on this day was that he was having severe swelling and now difficulty with ambulation, and that's why he wanted to be reassessed. He reported that he had walked around barefoot quite often while in Puerto Rico, but he had not noted any sort of inciting trauma or injury to the foot. And then he also mentioned that he did wear pretty heavy closed-toed construction boots most days of the week while at work doing construction, essentially. His review of systems, he denied any fevers, chills, numbness, muscle weakness. He did report, as I mentioned before, the swelling, the pain, there was that purulence and that strong odor associated with it, which was quite bothersome and disconcerting to him. And so this is what we were presented with in clinic. I apologize if the picture's a little too sensitive, but that's what he presented with. He was non-toxic appearing. He was fully conversant, but he did have limited mobility associated with any sort of significant weight bearing on that left foot. And so most of the exam really did just concern that left foot. There was a significant degree of pain with even light palpation and touch on exam. And as you can see, we're really holding that the ankle portion just because it was so painful to touch elsewhere. One can also appreciate the significant desquamation of the stratum corneum. There was pretty a robust maceration and purulence within the interdigit spaces, but also along that plantar and dorsal aspect of the foot. And there was also underlying erythema, mild non-pitting edema along that plantar and dorsal aspect of the foot that one can appreciate on this photograph here. All right. I know that we're on Zoom and people don't like to chime in, but would anyone like to share their thoughts on what tool we may have used in our clinic to highlight this? I'll give you guys like 5 seconds and then I'll just tell you. All right. So what we ended up using is a handheld woods lamp, which has a peak wavelength of around 365 nanometers. And that falls within the ultraviolet range, which we typically say is between 320 and 400 nanometers. And so we use it often in our clinics. And what it helps to fluoresce is that bright neon green that hopefully projects well as this coral red fluorescence that we talk about often. Just to give you guys a little bit of background, the physics behind the use of an ultraviolet light, such as a wood lamp, this allows phosphors, which are natural products that the skin and pathogenic substances produce, that converts that invisible UV light to a visible light, which we see as fluorescence. And so that green neon light sort of fluorescence that we see, we historically and typically associate it with a pseudomonal infection, with Pseudomonas aeruginosa being the culprit. And that bacteria essentially secretes a phosphor called pyoveridin, which fluoresces in this case. And that coral red fluorescence that we can see here, that's secondary to coperfurin 3, which is the phosphor produced by Corynebacterium, and that fluoresces. And that's really how we can differentiate, not related to today's topic, but really how we can differentiate erythrasma from underlying tinea infection, inverse psoriasis, other inflammatory dermatoses that we may not, that we need further information for. And so we find it really helpful to use in our clinic setting. So one thinks to themselves, you have this young male who has otherwise a pretty non-toxic appearance coming in with this pretty significant left foot that is painful, erythematous, swollen, and is now hindering his ability to carry out his daily activities of living, which is not great in someone who wants to work and to live his life in normal circumstances. And so what did we end up doing for him in the clinic setting? So we knew that he was non-toxic appearing, he was afebrile, hemodynamically stable. And so we were able to continue our workup and treatment plan in the outpatient setting. And in his case, our outpatient workup included bacterial and fungal cultures were obtained through swabs. We also screened for any sort of underlying diabetes and chronic kidney disease, just to ensure that we were working with normal renal function in the setting of needing to likely put him on systemic therapies. We didn't want to box his kidneys and ensure that we were doing adequate renal dosing if needed be. And then we also just wanted to ensure that he did not have underlying diabetes that may have contributed to either microvascular disease, immune suppression, et cetera. So those were the thought processes as to why we screened. We also wanted to make sure that he did not have any sort of underlying leukocytosis or even a leukopenia, which you can see in immune suppressed patients. And in his case, his white count was normal and he had a normal diff pattern, which was reassuring. And we were not at all surprised to see that his ESR and CRP levels were elevated, just given the significant inflammation that we noted on clinical exam. So that sort of tied well with what we were seeing. And so on day one of presentation, we really didn't have a whole lot of information to guide our therapies, but we certainly had some thought processes as what we wanted to treat. And so our differential diagnosis for him, of course, we were concerned about infection first and foremost. We were also concerned about gram negatives. We thought about a really bad bullous tinea infection. That came to mind, certainly. Other things that we thought about when we saw that clinical presentation was, did he have, chronic inflammation that had now led to an ulcerated non-melanoma skin cancer, such as a squamous cell carcinoma that we typically will call a marginal ulcer. We also even entertained for a moment, maybe this was a really strange and unusual presentation of an ulcerated non-melanotic melanoma. And then even before then, we also considered maybe this was an irritant or allergic contact dermatitis that had now had a superimposed infection on it. So these are all the things that we were thinking about. But when we initiated our empiric therapy plan, we were really focusing in on infection as being the main driver at this moment. And so that included initiation therapy with doxycycline, 100 milligrams twice a day, ciprofloxacin, terbinafine cream to help combat any sort of underlying tinea infection with dermatophytes. And then we also included aluminum acetate soaks, which are most commonly known as Dunborough soaks, and they're pretty readily available both in the outpatient and inpatient setting. And it works as an astringent, and it can be used 2 to 3 times daily. And the thought process behind the mechanism of action is that it's an astringent, and so it causes constriction of blood vessels, which you hope that reduces inflammation, and then really dries up sort of wet weeping skin via osmotic flow of fluids. And while we say it can be used 2 to 3 times a day, we typically recommend it twice a day just because of the ease of use. And nobody likes to take a medication 3 times a day, let alone having to do a soak 3 times a day. And so we recommended it twice a day. To soak for about 15 to 30 minutes, you pat dry, and then you apply any sort of topical therapies that may have been recommended. And so that's what we recommended for the patient to do until we got further data. So within a day or two, the culture data that we got back, notable for Pseudomonas aeruginosa, E. coli, and Enterococcus. Fungal cultures were negative growth to date up until the very end of incubation period, but we allowed our culture data to guide our therapy plan. And so we certainly made adjustments to it. And so we discontinued the doxycycline. We did not need MRSA coverage at this time. We did add a course of Augmentin to help with the Enterococcus mostly, but E. coli as well. And then we initiated treatment with clindamycin, which a topical gel twice a day to help with the underlying erythrasma that also might be present secondary to Corynebacterium, which we noted on our Woods lamp and which had fluoresced as that coral red, as I mentioned earlier. Okay, so just as a reminder to everyone who's either on the call or just joined us, this is what the patient's left foot looked like on the day of his presentation. So pretty significant edema, erythema, purulence. And at his 2-week follow-up, we made the following strides in his care. And so this is what it looked like now. And so there's less desquamation, though you would expect with such significant swelling and erythema that the skin between the skin folds and along that dorsal and plantar aspect of the foot, that you would expect that desquamative process to continue. But you can also appreciate that there is less erythema, there's less maceration between the interdigit spaces, and really no visible purulence at this time was noted, which was really good for the patient. And so again, just to highlight what we were seeing with our use of our Woods lamp, this is what it looked like on day 1 of his presentation. And at his 2-week follow-up, you can see that there's pretty limited, if none, of the green fluorescence and very minimal coral red fluorescence. And what you really do see, the coral red or orange fluorescence at this point, is just on the portions of the stratum cornea that will desquamate and fall off. And so that's reassuring. So what we have here so thus far for our patient's clinical course is that he did improve at around 2 weeks, but then worsened. And so what did we do at that time for him? We did obtain new bacterial and fungal cultures that we wanted to assist with antibiotic stewardship. We were concerned about hitting him pretty hard with all these myriad of antibiotics, antifungals, and we just wanted to ensure that we weren't missing anything. But in the meantime, we did resume the augmentin and the ciprofloxacin. We initiated Gentin Violet topical BID, and we asked that the patient continue using the clindamycin gel twice a day, the terbinafine cream twice a day, and to continue the aluminum acetate soaks as well. Repeat cultures, unfortunately, at this time, did note a fluoroquinolone resistance. And so at this point, we did consult infectious disease. And given that there was now resistance, they recommended the placement of a PICC line and the use of Zosyn for a 14-day course. They also noted that he may benefit from an empiric treatment for dermatophyte infections, such as underlying tinea with oral terbinafine for 14 days, and then to continue all of the topical therapies that we had him on, as well as really good wound care management. And so given the patient relapsed, the big thing that we took away from it was that this patient has underlying risk factors. He had, the use of his occlusive footwear, being in probably sweaty, dirty socks a lot of the time, just because of his work and not being able to change out as often as he would want them to. Humidity, occlusion, et cetera, that he probably warranted a maintenance therapy. And so that included the use of terbinafine cream twice a day and acetic acid soaks 2 to 3 times a week, which I'll get to in just a moment as to why we did that for him. And so the diagnosis that we gave our patient was a severe mixed toe web infection. And so this is also known as a gram-negative bacterial toe web infection. There is a pretty robust systematic review that was published in 2017 by the Journal of European Academy of Dermatology and Venerology. And they had data mined from 1980 to 2016, and in the end had included 7 publications as part of its systematic review. And what it noted was that there is a lack of data on the incidence and prevalence of this diagnosis, both in Europe and abroad, and that probably has to do with how it's identified by key players, and that includes, treating physicians from across the board, family medicine, internal medicine, dermatology, infectious disease, of course. You can even have surgical specialties play a role here. And so I think how we identify it, how we treat it, probably contributes to that lack of data. What the systematic review, though, did nicely is to identify key risk factors and complications for us. And the number one risk factor that they found was interdigital tinea. So lack of, inappropriate or untreated tinea can certainly play a huge role here, and is probably the number one cause of developing this severe mixed toe web infection, with gram negatives being the likely culprit. Other risk factors that they noted were hyperhidrosis, which is excessive sweating, occlusion, humidity, which we see often in people who have to wear occlusive footwear for work, et cetera. Underlying diabetes certainly can play a role here due to either microvascular disease, underlying immune suppression, lack of glucose control, et cetera. And then also the inappropriate use of topical and systemic steroids can also play a role here. Some of the risk factors that they noted, which we saw in our patient, which is relapse, and this is likely due to those underlying risk factors that were either not addressed properly or were ineffective when they were addressed. And then something that we see often is this autosensitization dermatitis, also known as an id reaction, which we typically see with tinea infections, but you can see with a lot of infectious etiologies, which is essentially a sympathy rash that will arise elsewhere on the body that also warrants treatment, of course, but getting rid of that initial, the underlying infection that may be on a different body part, et cetera, is where the treatment comes into play and is most often seen when we can see good results with treating an it reaction. And so the one question that I had, and it's highlighted a bit in the literature, but not as well as I would have hoped, is that though tinea infection is likely the predisposing condition, why don't we see a positive fungal culture or KOH preps that we often do in clinic? And that is where the data becomes less. And though studies have postulated, there are some culture-based studies that have postulated and have shown that there is certainly a reduction in inhibition of trichophyton species in this setting and robust growth of Pseudomonas aeruginosa. And this is likely due to the creation of a biofilm that inhibits its growth when it's so robust in itself. And then also the production of piocyanin, which is a phosphor that Pseudomonas aeruginosa makes, has demonstrated to have antifungal properties. And so what I think happens here is that because you have an overgrowth of your Pseudomonas, you're not going to see those fungal cultures or KOH preps be positive. But as soon as you begin to lessen that burden of Pseudomonas, you have underlying tinea still present that goes untreated. And if you don't address it in a timely manner, then it becomes this vicious cycle of having underlying tinea and then having recurrence of gram-negative infections, et cetera. And so in that same 2017 review article, the authors concluded by adding an algorithm for both the workup, treatment, and follow-up plan to assist with this diagnosis, since there is such a paucity of data out there. And as stated previously, getting that necessary data is much needed, and I would highly recommend it, that I think it's necessary. And while I agree that such flowcharts are helpful, I am a bit hesitant to agree with their assertion when it comes to the treatment plan. And that's for the following reasons. So they recommend a 10-day course that they state is sufficient to eradicate such a significant cutaneous disease infection. And while we know that for epidermal turnover to occur from the basal layer to the last viable layer, which is the granular layer, that average time is roughly 28 days. And from the basal layer to full desquamation, it can vary anywhere from 52 to 74 days. And that really has to do with the site and thickness of the stratum corneum. And while I would never recommend using antibiotics for, 52 to 75 days, I would recommend a longer duration of treatment so that one takes into consideration that actual turnover time of roughly 28 days. So one may consider a 2 to 4 week course might be more adequate. And that may also give you time to address the underlying risk factors and to mitigate or reduce those, and so that you can achieve complete eradication and then hopefully reduce future resistance patterns from arising from overuse or multiple uses of antibiotics in the outpatient or inpatient setting. And then lastly, I would be wary of debridement. I would say utilizing specialty care who has knowledge of both the skin barrier and to which depth and margin one would need to achieve adequate debridement, and then to be able to offer wound care management post-debridement. These are all things that I would highly recommend and should be a takeaway from this talk, is that possibly increasing that duration of treatment, but also how to use and when to utilize debridement so that it's efficacious and not harmful to the patient is important. But the rest of it, I would agree. I think it's important to check your antibiogram and to compare treatment, compare current treatment algorithms. I think looking at resistance patterns, we would all agree is very important. And then, the need for repeat bacterial and fungal cultures. I think sometimes we tend to anchor on what we have in front of us from our initial assessment, but that may not always be the best for our patients. And so to repeat something that you may have done already, there's no shame in that or harm. And I think it's important. And then going back to the drawing board, I think that's also really important. Consider a skin biopsy, consider sterile tissue cultures if you're not getting adequate improvement, at least after the second time, and then assessing for underlying immunodeficiencies, and then also strongly consider a contact allergen that may be playing a role here. If there's a alteration in that skin barrier due to hypersensitivity reaction from an allergen, that in itself can become a risk factor and a nidus for infection to take place. And so, as I mentioned before, for our patient, just because he relapsed, we realized that we wanted to achieve remission in our patient. And so how do we do that so that he could go back to work? And so what did we do for him? Well, we recommended for maintenance purposes that we continue the topical antifungal treatment indefinitely, just because he was going to continue to wear occlusive footwear. There was going to be a high chance of humidity playing a role here. And dermatophytes love that kind of environment. And so that seemed to be really important to us. We also actually recommended a one-time treatment of all of his footwear with a miconazole powder, which he stated that he did. And then we also recommended the use of a dilute acetic acid soak, which is essentially vinegar. And so I apologize if this chart is a bit grainy, but what I wanted to highlight is that this is an oldie but goodie therapy that I utilized a great deal while I trained down at VCU. And I'm hoping that the same holds true at our dermatology department. And so it's a very dilute acetic acid soak, and it has a pretty unique mechanism of action as to how it alters the milieu's pH, which allows for both infection control. It reduces bacterial protease activity. It promotes wound healing by the release of oxygen reactive species. It even increases macrophage fibroblast activity. And it has been hammered into us that macrophages are the most important cells in wound healing. And that's something that's tested quite often in our dermatology boards. And then also it does promote the destruction of abnormal collagen within a wound bed. And so not only is it safe, efficacious, it's dirt cheap, and it's something that patients can do at home with very minimal cost to them. And so this is the acetic acid soak, essentially instructions that I use throughout my residency. And I found it to be really helpful because it helped to highlight why we're doing it, what the directions are based off of how much a patient needed or wanted to make at a certain time, how to use it. And then also, to state that there are other creams and ointments that will likely need to be put on after the soak is completed, which I thought was pretty comprehensive and user-friendly for our patients down in Richmond. So before I move on to case presentation 2, some key teaching points that I hope to have highlighted for you all is to always think of your initial differential diagnosis. If a patient is not clinically improving, go back to the drawing board, obtain more data. And that's something that I took away from my training, is that obtain all of your possible data to assist with your diagnosis. Identify potential barriers to a patient's lack of clinical improvement. Just because we prescribe a medication doesn't necessarily mean that the patient has transportation to pick up those medications, has the health literacy to be able to read those instructions and also to use the medications as they were prescribed, and also the barriers to actually being able to afford certain medications. In the world of dermatology, I know a lot of the topicals that we recommend can be costly. And so we always keep that in mind when we prescribe certain medications for our patients and the quantity that we prescribe. And then also always consider an alternative mode of treatment with topical therapies when there's low to no concern for systemic involvement. So while for our patient, we ended up needing IV antibiotics, we may not always need to go that route if we utilize other treatment modalities such as topicals, orals, etc. And then if there's a suspicion for recurrence, consider a maintenance therapy plan. A lot of what we do in the world of dermatology is maintenance. You know, people will have they'll have skin, hair, nail disorders that require long-term treatments, and setting up expectations for our patients is key, and also to help mitigate that, you know, the risk for relapse, I think is important, and will instill a better patient-physician relationship, I think, in the long run. So those are my key teaching points, and I'm going to now move on to case presentation 2, which will, I promise, go much faster, and then I'm more than happy to take questions and any comments that you all may have. So for case presentation number 2, we had a 68-year-old male who had a history of a heart transplant for ischemic cardiomyopathy, who presented to the cardiology service, not to us, thankfully, for a right heart catheterization to assess for an underlying graft versus host disease, as well as a workup for potential new heart failure. So the patient had reported to his heart failure team that he was more tired, short of breath, and just wasn't feeling all that well. And so they were really concerned, given his recent heart transplant, cardiac transplant. And so they had him come into the cath lab on an urgent basis. And so on arrival to the cath lab, he was pretty ill appearing, and his hemodynamics were notable for a sinus tachycardia. He was admitted to the heart failure / transplant team for further management, with a focus on a potential transplant rejection and infectious etiology, given his chronic immune suppressed status. And so you all might be wondering, why was dermatology involved in this patient's care? And so when the patient had arrived to the cath lab, the team had noted these sort of blotchy red patches that were pretty prominent but ill-defined in terms of sort of where they're scattered, their size, etc., all across his trunk and upper extremities. And then he had mild erythema on his lower extremities. And they really did not know what to make of this. And on further questioning from the patient, he himself really couldn't give a whole lot of history either as to when they came up, had they been progressing, had they changed or evolved in any way. And so that is when we got the call on the same day that he had his cath to see him in the inpatient setting to help with their assessment and to come up with a plan for him. And so this is what he looked like in bed on that same day. And so just to note that his lab findings revealed elevated troponin levels and a leukopenia. His physical exam was notable for well demarcated, but these sort of dusky erythematous, there were some circular, some ovoid patches, and very thin plaques across the chest, back, and upper extremities. And as I mentioned, he had some mild erythema on his thighs, but otherwise nothing as prominent as we can appreciate here on his chest and abdomen. And so given the data that we had and what we were dealing with, our differential was all over the place. We really didn't know what we were dealing with. But at the top of my list was initially a fixed drug eruption. And the reason why I thought about that is that there's sort of erythematous, sort of dusky, ovoid to round patches and thin plaques, which makes me think that there's a dermal process rather than an epidermal process happening here. He had very minimal surface changes. Other things that I thought about was sweet syndrome, erythema multiforme. I always have graft versus host disease, just given his underlying immune suppressed status. I thought about maybe he had some isolated tinea infection, and now we were dealing with an id reaction, but again, very minimal epidermal changes, which we often see with an id reaction. And then just because of how ill appearing the patient was, given his chronic immune status, we entertained infection too, but I really did not have a good sense of what infection I might be dealing with here. And so while I added it to my differential diagnosis and entertained it, I really didn't know what I was dealing with. And so keep all that in mind as we move forward here. So the first call so we always send our inpatient path as stat. And so that means that we typically get a turnaround time of around 24 to 36 hours. But we had amazing dermatopathologists down in Richmond and would easily pick up the phone and talk to us and walk us through things. And so when I got that first call from our dermatopathologist, he was like, Freba, I don't really see a whole lot. And mind you, I had given him a punch biopsy for both H&E and tissue cultures that had been sent off to micro. And so at 10x magnification, he was like, all I really can appreciate here is that there's edema within the dermis, and there's a very mild inflammatory infiltrates in a perivascular fashion, but the epidermis looks intact. I don't see a whole lot here that I'm working with, but I will continue to look and I will let you know if I find anything. And so, of course, me being me, I was like, well, did you see any signs that could fit with fixed drug eruption? And he said, no, I don't see any of those things. And we walked through that a little bit as to why that wouldn't fit. And so typically for fixed drug eruption, you classically see an acute, what we call an acute or normal stridum corneum. What you see are mostly chronic dermal changes within the papillary dermis. So you'll see papillary dermal fibrosis. You'll see melanin pigment incontinence. So essentially melanin dropout from the basal layer. And you'll see that sort of along the perivascular location. You'll even appreciate more of a vacuolar interface dermatitis. So that just means you're going to see vacuolization or essentially holes along the basal layer of the epidermis. And then you're going to see that interface dermatitis between the end of your epidermis and the beginning of your dermis, where you're going to see a robust inflammation. And that inflammation typically will involve both lymphocytes and eosinophils. And he didn't really see any of those changes, but he said he would keep fishing around and let me know if he finds anything. But to highlight that you typically see a mismatch between a normal stridum corneum and then the chronic changes in the superficial dermis. And that's due to the fact that with fixed drug, by the time it comes to our attention, you've had repeat exposures to certain medications, and that cutaneous phenomenon typically comes in the same place. And so you'll see those chronic changes arise as well. But in this case, we're not seeing any of that. About 5 minutes later, I get a second call from Dr. Moschel, and now at 40x magnification, he noted these small aggregates of mastocytes within macrophages. And that prompted a slew of other tests that we needed to do for this patient. Infectious disease became more heavily involved in this patient's case, and it even prompted hematology to get involved. At which point we got a peripheral blood smear in oil immersion, which showed a trypomastocyte. So that was pretty telling. So based off of the skin biopsy, which stained with H&E, it revealed that dermal edema that I mentioned, and then these small ovoid forms with a distinct nuclei and kinetoplasts that were consistent with the mastocytes. The patient's peripheral smear also became positive for Trypanosoma cruzi. And so what we ended up diagnosing our patient was a disseminated T. cruzi infection with both cutaneous and cardiac involvement. And subsequent serum PCRs and serology testing was sent to the CDC for confirmation. And so the patient was started on a 90-day course of treatment for the T. cruzi, and both his cutaneous manifestations dissipated and eventually disappeared within a couple weeks of treatment, and his repeat peripheral smears also became negative for T. cruzi. And so this was a very rare case of disseminated Chagas, but what I hope to illustrate is that cutaneous infections lesions can very, very much so mimic inflammatory dermatoses. So having a broad differential diagnosis for this patient was a must, based on his history, his immune suppressed status, and his initial clinical appearance. I think it was necessary to keep all of those things in mind. And though Chagas disease is a very, very rare cutaneous, has very rare cutaneous manifestations, we often don't see it at all. Even in our Bologna text, which is sort of the encyclopedia for dermatology, it has very little discussion on the cutaneous manifestations of Chagas disease. In our geographical area especially, I think it's important to at least have that comprehensive differential diagnosis. And then in the era of increased globalization, increased numbers of heart transplants, et cetera, I think it's important that we at least keep it in mind and consider it in the right context and in the right patient population. And with that, these are my references. And I thank you all for your attention. And if you guys have any questions, I'm more than happy to answer them.